all for joining us today. I will just transition between our intro slide to our presentation, but I want to tell you how excited we are to have you here with us today and to be getting the opportunity not only to have all of our fabulous collaborators join together, but to be able to share this topic with you that I know is near and dear to all of our hearts. I am Janine Abrams. It is a pleasure to meet with you. I am one of the executive council members for the FIP academic section, and this is our webinar for the month. We are focusing on the development of culturally and linguistically appropriate services and collaborations in pharmacy. So we'll start our presentation today by really trying to cover the different components of culturally and linguistically appropriate services. And I will set that stage, but ask my colleagues to join in and to share some of their perspectives on some of the techniques that we do with that to add on little points of information as we progress in our understanding and our approaches to trying to provide the appropriate care to the patient populations that we work with. We'll also talk a little bit about the role of social determinants of health and understanding individuals' lives as we look at that. Thinking about the principles of global health and mutually beneficial collaborative partnerships. And then talking about, again, kind of this role of sustainable development goals as we think about how those touches many of the things that we do in our life. And then our primary point that we hope to provide you today is an example of ways that we have been able to take different components and resources and to incorporate multinational perspectives and interprofessional perspectives as we look at the provision of services. So as we start our day, or you end your day wherever in the world you are, and again, please put in the chat where you're from, where you're joining us today. We would love to know that as we progress. What is culturally and linguistically appropriate services? They are services that respond to a person's culture and their communication needs. So as we think about this and think about class, we need to start thinking about cultural beliefs. We need to think about preferred languages. We need to think about health literacy. We need to think about communication needs. And as we are designing our services, we need to think about how to be respectful, understandable, effective. So I'm going to call on Deb for a moment with this because I know this is one of the things that Deb and I have talked about. Deb is a coordinator of a nonprofit management in Iowa City, Iowa. She has been working with numerous populations, and I'll let her mention those kind of backgrounds. And then she also provides services in Guatemala for cleft palate surgeries, working with different individuals. So Deb, I know that Open Heartland primarily works with patients that are of Hispanic or Latin descent. Can you tell the group some of the different countries or regions that are represented in that population that you're developing services for?
Thanks, Janine. I'd be happy to. So Open Heartland does health mobile clinics, primarily with families from Mexico, Guatemala, Honduras, Haiti, El Salvador, primarily Central America. And one of the things that we've learned that's been really important to us is, yes, the majority of the families speak Spanish, but the families also speak a lot of indigenous languages. For most of our families, Spanish is their second language, not their first language. And so for us, one of the things we've learned is to really slow down, to make sure that when we speak, that we really articulate, that we try not to use English slang, that knowing that when you learn a second language, sometimes you have to slow down for understanding. And then I think the key thing, Janine, excuse me, is just to be really, really friendly. Facial expressions mean a lot when you're communicating in another language.
That's really great, Deb. I think that I know as I've worked with you, one of the things that we've talked about with development of translator services or materials, for example, is to vet those resources with the populations that we're working with because there can be different word choices in different locations that make that meaningful, and to supplement with multiple approaches. So, we have a lot of resources for counselors like Spanish language sheets to be able to point and to at least have some written communications if you're working with somebody that is maybe translating on behalf of their family, or we have a lot of student translators that are translated or trained in translation services, but now they're trying to think about how to apply that, or if there's not an understanding how to adapt that. And I know we also talk about visual imagery, and then, as you mentioned, all the nonverbals that really help us in that process. So when I first started working with Deb in that component, I recognized that there were times that I was seeing some of those things that was saying our service, even though we are trying to be respectful and understandable, is not hitting that mark. And again, we'll talk about how we've incorporated components in there.
One last thing I'll add to that is that for each patient, when we use interpreters, we try to use one patient advocate throughout the entire process so that the patients are dealing with one interpreter the entire time that they're going through the health communication process. That
Yes,
way
and
they
I think
kind of
that's been
develop,
helpful.
they're able to spend some time together, develop a little bit of a relationship so that the interpreter will have a stronger sense of whether the patient really understands what's being communicated.
Yes, I've learned so much from Deb with those components as we've thought about how to apply that. And I say, Deb really motivated me in COVID to learn and to improve my language skills. So I think I am at day 900 in working on my Spanish and working on medical Spanish and linguistic approaches as well to become more effective in that area. But again, learning every day, every time we provide the services. So thank you, Deb, for that. Um, I am going to ask Jane to say for a moment, Jane, I know that when we're devising different resources and we're thinking about health literacy levels, we need to think about the language preferences and the level of language. So can you provide, one tip that takes class into account when you're developing a material to support your service?
So thank you, Janine. Yes, what we usually try to do is we try to develop the portfolio that is about a sixth grade level. And we incorporate a lot of times some visuals, so pictures, so that it makes it easier for them to understand. We try to make short sentences so that it's easily readable, and then better for patient understanding.
That's great, Jane. And I know a lot of times as we are working with students, and we'll touch on this more as we progress through the webinar, we will have to provide some tweaks to kind of think about how that is, again, providing that information and getting feedback from local partners or collaborators to say, how is this effective, or what can we do to modify that further? So I really appreciate that example. Jane is a instructor in the laboratory sequence at Albany College of Pharmacy and Health Sciences, where our own academic section president, Toy Intifada, is located. Jane initially began collaborating with me and Dominica about 15 years ago, and she has been a constant partner in, again, kind of helping and designing services that meet the needs of the different things that we do with our team. and working with Carlton, who we'll talk later on, to really incorporate approaches. Ashley, I am going to call on next. Ashley is a former student of mine that has training in data analytics, data informatics, and design. She completed a residency, a PGY1, which in the United States is kind of our initial residency component. And then she did a second year of training in that, really focused on this area. She's developed apps that are used related to services throughout the US to really connect different patient populations, oftentimes veterans, to the resources that are provided. And Ashley is working on a project that she'll touch on more as we progress, but that really looks at the use of open source technologies, particularly designing computer programs, electronic health records, and apps. And that app formation has been directed not only at Dominica, but also at things like Deb's patient population and the mobile clinic services that we provide collaboratively that are in Iowa City and addressed for about 14 different community care and partner sites, ranging from community organizations to churches to restaurants where we'll provide care. So Ashley, I know one of the things that you and I have talked about as we've selected programs is this kind of preferred language. And as we looked at the language components, how do you think about looking at whether or not a system has those approaches? What do you think the roles of open source technology is in addressing more languages?
Absolutely. So the beauty of open source technology is that a lot of times it allows a lot of different collaborators to come in. And the beauty in that is if you have diversity in who's able to actually contribute to that open source, you have an extended ability to get a bunch of different languages in. It also really goes to show about the scalability and sustainability of open source materials, right? So you can use it across many different types of populations. The other piece to this too is that you can automate a lot of these things. And you touched on some apps, which that also helps. But if you can bake in an automation to where you've got these preferred languages that are available, it's accessible to folks to putting that information into open source. You're able to access all sorts of different languages and getting your resources, your information that you need to give to end users or to patients in a very quick and easy way. And so that's one of the beautiful things about those open source technologies is it allows for a lot of customizability and like accessibility across a lot of different groups.
Thank you, Ashley. And I am seeing in our chat that we have individuals from Africa, from Argentina, from Indonesia, from Pakistan, from the Philippines, from Ethiopia, Philippines. We have some amazing, it looks like diversity in where you are all joining us from today. Norway. Some of these open source technologies did start in Africa for their applications. And I know a lot of groups that work collaboratively related to that. And again, thinking about how this could apply. But again, I think the program that we've been working with has also chosen, I think we were at 30 plus languages, correct?
Yeah, that sounds correct.
Yeah, so a lot of really great opportunities to think about how to apply that. And thank you, Ashley, for chiming in there. So as we think about how we would develop a service based on class, really, again, we need to be responsive to the demographics of our individual communities. So although we're talking about this from how we've utilized some of these services in Dominica collaboratively, and then also in Deb's work and in caring for patients in the Iowa City area with backgrounds and lives in Honduras, Guatemala, Nicaragua, Mexico. Again, each of the time we look at these services and resources, we have to think about what adaptations need to be made to fit the needs of that community. And as we're doing that, our really purpose is to think about social justice issues and to think about how can we reduce or eliminate any disparities in the health status of people that have diverse racial, ethnic, and cultural backgrounds. So again, thinking about all of the individuals that we represent and making sure that our standards of care keep in mind their cultural lenses and their cultural mindsets. So as we have developed services and we've thought about trainings, the group met before this to pre-plan and to put things together. And as we thought about those components, really this has to be something that you incorporate from the start of the design of your programs. And again, as you modify different components throughout programmatic design, really that entrepreneurial mindset of having numerous reiterations and really trying to work together as partners to make sure that we are getting our policies and trainings correctly, making sure that we're getting our language assistance and our communication, in a way that is meaningful, and to engage in continuous improvement and accountability. So I am going to ask Deb again. Deb, I know that in COVID, as we started to develop some of our resources and components that we were trying to connect with different patient populations in a way that we would have those services be accessible. Can you give the group just one example of a modification that we had to make or remake over time as we provided those services in a mobile clinic setting? So at your community organization, to make sure that it was going to be at a time and a place and in a way that worked for patients.
Sure, Janine. For the mobile clinic that comes to Open Heartland, the time of the week, so this is a very simple example, the day and time of the week that is most doable for the medical professionals is generally like a Sunday afternoon. However, we found that when we started doing our clinics on Sunday afternoon, that not a lot of our Latinx families actually attended the clinics. And after a little bit of exploration, so instead of just relying on the availability of the medical professionals, when we actually talked to families, and we knew that families wanted the services of the health clinic. They were in great need of these services, but most families either had religious services on Sunday afternoons or they were still working. So for the families that we serve, most of those families work on the weekends and don't have the accessibility to come to a mobile clinic. So what we tried to do to take that into account is schedule our clinics later in the afternoon. So they started more like 3 or 4 o'clock in the afternoon once people got off work and once the religious services were over. And I'll say that doing something as simple as that, not only does it make the clinic accessible, but it shows respect for the people that are trying to be served with the health service.
Yes, and I know, Deb, I give an example that once I tried to develop something in Dominica, and I was trying to paint a sign for one of the clinics that we were doing. And I really thought that I had listened, I had heard everything, that our partners who I love, were helping, and they were having these pauses as they were saying it to try to tell me not to paint the sign. And the sign ended up being something related to construction. So I had thought that I was being helpful. Again, as I reflect back, I think that was more helpful to me to want to put some location there that was meaningful, or to think that I had contributed. But I know as we were talking about Open Heartland, I felt that I had heard the timing again. And I know we also tried providing the service on a Friday night. To me, that was the weekend when individuals had provided that comment. And we had a few clinics where we did not have a lot of attendance. And thankfully, you and then one of the women in the women's group said, Friday night is not necessarily the weekend for everybody. So I want to thank you, Deb, again. I think that reminds me that interpretation, that improvement, that reflection for us as healthcare professionals has to be constant. Just when we think we've learned a lesson, there's another lesson as we work together in something that teaches us a little bit different about that. So that's a great example. I appreciate you sharing that.
Sure.
Okay, so as we continue on and think about that too, again, we are doing these constant reiterations with Jane and with Dominica and with Ashley. I know that we have gone through multiple reiterations, Carlton as well, to think about how to adapt the different things that we do for students or what those programs look like. And again, I gave an example of doing something to hopefully benefit the community, but needing to adapt that as we moved in putting together resources or signs. So our program has tremendously evolved over the years. But as we look for toolkits or resources, and this ties back to the advocacy, policy, and change management series that we're doing worldwide, where we are looking at stakeholders and policy leaders, and they're sharing their advice to us. It is really important that we just don't take a model and we apply it to every situation, but that we think about those cultural variations, those cultural adaptations, and thinking about how to understand what the rules and beliefs are in different locations with different individuals, but really thinking about how to make a service feel safe. And that may be thinking about texting and messaging with patients, thinking about how they feel with that provider. Deb mentioned for us thinking about that consistent translator and how that makes that individual have another point of stability in the service to make sure that they are feeling like the service is being responsive to them, that they're safe and they can trust us as healthcare providers. And then again, we gave that example of working within individuals' lives to think about the preferences of the group. So as the service development continues, again, we start with those policies and trainings. We need to think about how our different collaborators, different members of our team are continuing to represent those services, because it's not just us providing the care, it is all the people that we work with in the development of services that have to have this shared approach to really want to be invested in the process. And thinking about, again, different creative positions. So one of the things that Deb has done at Open Heartland, I know, is thinking about community health workers and community health workers' roles with connecting with different individuals and also advertising clinics and services. And again, I think that's something that really applies to Dominica as we have worked together to think about how messages are getting to people. Is a message that is sent on an email the best way, or what is that way to reach people? Deb, please jump in and let me know kind of what your thoughts are with that.
One of the things I'll add to that, Janine, is that here in Iowa City, our typical way of communicating is through email or text messaging. And what we found out is that most of our clients, most of our families here in Iowa City that are Latinx do not use email, so that doesn't really help us. And text messaging has a cost associated with it. And so we have started using WhatsApp to communicate with all of our families, and we have formed WhatsApp groups so that certain families living in certain smaller communities, some families will get the message, they'll share it with other families. We also use this in Guatemala when we're in Guatemala doing the cleft lip and palate medical missions. And I think one of the most impactful aspects of using WhatsApp is that once our medical team has returned back to Iowa, I still communicate with our patients all year long. It may or may not be about the medical situation that we were involved with when we were in Guatemala, but it continues to build the relationship. It continues to help our patients feel that we care about them, that what we do is just not a one shot. We fly in, we do some medical service, and then we fly out again. But again, it continues to build that relationship, so that WhatsApp has been really powerful in communication for us.
And I would say that is the same as well. So I'm going to see if Carlton is on to join us. Carlton, are you on? And have you been able to connect with us? I'm hoping that you are here. If not, I am continuing when I am not speaking. We have had just a little bit of technical difficulties in communicating over WhatsApp to see if we can resolve those and to get connected here. Jane and Ashley also know that for Dominica, we have a text group, again, a WhatsApp group that shares that information. So Jane, can you kind of talk about how that is important to you for just a second to, again, keep those relationships and to work together in our preparations?
Yes. So thank you, Janine. And as Deb said, we've been able to, through WhatsApp, has allowed us to assist some of the individuals in Dominica, both near and far. When we're there on site, we're able to communicate and put information in there. They are very adaptable with that. And then once we come back to the States, when they have some questions for us, we're able to communicate through the WhatsApp venue. And by having some group with our medical team that's down in Dominica and our resources there, we can kind of triage over, the oceans so that we're able to help those individuals. And it's worked quite well.
So again, as we're thinking about this, that accessibility piece becomes very important. So Jane mentioned WhatsApp, Deb mentioned WhatsApp. Again, maybe providing resources or providing platforms to collaborate. We'll oftentimes use Google Drive because, again, that does not have the same subscription or challenges with accessing that service. We will think about apps like Google Translate to help and assist in translation services. And even thinking about if we are selecting articles or publishing articles, how is that selected or published in a place that is accessible worldwide, and again, doesn't have that subscription or that additional fee structure that is there. So thank you, Jane, for chiming in as well. I think it's important to see, again, how those resources apply to multiple different situations. We also need to know that, especially as we work with different individuals, and this might be for ourselves as well, that we have to remember that we are a product of our experiences that we've had throughout our life. And that can be the events that we've experienced or we've faced in our journeys to become healthcare providers. That can be examples, again, of that experiencing of health inequity or both positive and negative experiences with the healthcare system and with different individuals. But that really influences the effects on different groups and their functioning, in their spiritual and wellness and well-being. Even how we define health as individuals, I think, can vary. And so as we're considering those lives of the different groups that we're working with, we need to get to know each other to really know how can we make a difference? How can we be impactful together as a team effort? So one of the roles that I really do primarily, and then Jane works through this, Ashley, Deb, all together in different ways, is the training of the individuals that we work with on backgrounds of cultural awareness, talking about, again, historic knowledge of different health systems or different cultural challenges, barriers, and issues, and the impact globally that that has on our lives and on the structures that exist. thinking about, again, the development of those attitudes and where those attitudes come from, or where those health beliefs come from, making sure that our services think about the beliefs, values, customs, and practices that we practice in our day-to-day. And again, understanding each other. So Deb gave that great example of looking for nonverbal cues. There have been some different things out there that talk about some of the things in Iowa or in the Midwest that we say that we don't even think about if we're agreeing to something. I'll sometimes find myself saying no, yeah, or yeah, no, which are slightly different meanings, but one can mean yes, yeah, I'll do that. One can mean no, yeah, I don't know what you're talking about, or I don't know why we would be doing that. But as we're actively listening, again, that intonation, that pause can tell us additional meaningful things, looking for those facial reactions and thinking about, is somebody communicating to us in a different way that something is working or not working for them. And then thinking about how we recognize and appreciate differences. So Deb, I don't know if I've said this to you, but I think one of the most meaningful things for me in COVID, as we were providing our services, when we did adapt that clinic time, is I remember one of the women's groups one time brought us a home cooked meal that they had prepared. They brought it to the clinic. We didn't know that we were going to do it. And we spent time for an extra half an hour or hour eating together. You know, how do you think that plays a role in, again, developing these friendships or those relationships?
I think, and thank you for that question, Janine. I think when it comes to healthcare, there has to be so much trust between the patient and the provider. And here in the United States, that kind of happens naturally in this culture, but that isn't always the case. And so with the families that Open Heartland serves and the families that we work with in Guatemala, that trust has to be earned. And in my mind, there's no better way for anyone from any culture, anywhere, to bond than over, a little cafecita and some food. So taking the time, and that's another big factor, is time. Here in the United States, we're very, very rigidly scheduled. We have a certain amount of time with each person we're interacting with, and that is not the case with the culture that we work with. And so taking that time, having the respect to show your appreciation for sharing food. I think another big component in this is just curiosity. So not only appreciating the food, the time, the people that you're working with, but being curious enough to authentically care about learning more about the culture that you're working with. So yes, I think taking the time, having some conversation that's not health related, learning about their life experience, their family, their background, all of that helps build the trust that patients need with the medical profession.
Oh, and Deb has had coffee with me, and we've done other things. We've shared messages, again, just to create those relationships that blossom into a friendship over time. Ashley started out as my student and became my friend. Jane, again, started as a colleague, and I say my kids really refer to her as, again, another grandma or abuelita, as they're thinking about different relationships. And our partners, again, that we've worked with in Dominica have become extended family, not only to myself, but I know to Jane, to Ashley, again, to our families that have been there. And again, that's a mutual appreciation. Carlton, I know this year and every year invites us to do something that is more social as a group, and also, invites us to his home, invites us to join in the employee appreciation parties. And again, that is really meaningful too, because those are moments for us to know each other even more as friends and to appreciate how we can work together. Now, I think that as you're thinking about the development of services, it is important to know that we want to just really think about not only the individualization of that, and that is tough sometimes for students, for individuals to think about I have developed approach for a group, but now I'm trying to individually adapt that in many ways and to get to know that person rather quickly that I'm working with. But Deb mentioned that really has to do a lot with that empathy we have for each other, recognizing the own lenses and biases that we have, and thinking about how we're collecting and processing information, addressing barriers, and then again being proactive. And that trust needs to continue over time. So again, it's not something I always say with mobile clinic that we can develop trust and then we've got it and then just call it a day and we move on. But we need to continually be trying to work together in that approach. Now, some of these things relate to something called the social change model with Wagner and Calmives. But as we think about this model, we need to know that there are some mistakes that we can make as we design a culturally appropriate service. Again, Deb and I gave you a couple examples of maybe some of the paternalistic approaches where we had an assumption of maybe what a service was or what a preference was. And we needed to think about how our individual values and our consciousness of our preferences were intersecting with the community values, and then how that forms, again, that group value overall, and how we are working together to establish that. Another example is thinking with a deficit mindset. So thinking that we don't have any choices. So I'm going to call on Ashley for a second as well. Ashley, as we're thinking about designing a service and you're thinking about all the different open source technologies, how does that really change our situation for what we can use and afford related to technology? Electronic health records, apps can be very expensive. So how do we apply this to thinking about developing infrastructure to support something?
Sure. So, I mean, when you think about the resources that are available, there's all sorts of, there's a variation of services that you can really work with and use. So if there's something that's not affordable for you, we can find something that's a little bit more cost efficient, but then finding something that has that customizability and you're able to work off of that, right? To scale it up. So there's almost always a resource available to fit your needs. You just may have to modify it and adapt it a little bit so that you're not boxing yourself in too much. What I like to do personally is, instead of thinking about all the problems that could be occurring, think about solutions and being solution oriented. And when you're able to adapt and think outside the box in that way, you're much more likely to be successful in finding something that you need. And again, being able to modify it as needed for whatever your needs are.
And again, that might involve a lot of systems, right? So, as we've worked with our clinic components, one component is working on an inventory app with a Google app to think about, again, medication stock levels and supplies, and working with Jollies for replenishment points versus having that entirely in the open source system. So thinking about how do those pieces fit together. I know one thing that we did also talk about too is how those systems work together too. So not wanting to have too many resources simultaneously that are going to do something. As you're thinking about that, how do you incorporate that into your design to make sure that you're, looking at the appropriate solution?
Yeah, that's a good question. A lot of times when you're needing an additional resource or you need a new technology, you basically know what your needs are. Sometimes that may evolve over time, right? I tend to lean and gravitate more towards things that are a little bit out of the box, but allows more of that customizability, right? And just the ability to be creative, right? So thinking about that inventory app, there's software out there that's available that we could have bought and we could have downloaded and it could have handled all of our inventory for us. But that wasn't really a sustainable solution for us. So thinking about different ways that you can use the same technology for multiple different uses, there's so many free options out there, right? And so that's just something to think about. Is your resource able to have interoperability and to interface with other things? And 9 times out of 10, it is possible. You may have to get creative, but thinking about those different ways that you can sort of build these pieces together, looking at that whenever you're first looking at the resource itself, right? So like, is it open source? Are you able to talk to it with other softwares and interfaces? And if it at least has that capability, then you know that there is some way to make that work in the future down the road if you need it.
Very important. And again, maybe looking outside of pharmacy to other professions and looking at the resources that they use. It might not specifically be designed for our pharmacy purpose, but then thinking about what are the modifications that would be needed to ensure that we protect our patients' information, but then also to think about how that tool could be applied in a different mechanism. So I like your example of creativity. Thanks, Ashley, for kind of approaching that. And then you did talk about the cultural differences again, because it might be the preferences of those users in a system, and all of our preferences together. It can't just be one. We have to think about how everybody will utilize the things that we create. So the social change model, again, thinks about collaborating together with that common goal and really putting that together for that common purpose. But as we develop our culturally and linguistically appropriate services, we can have differences arise where we will think that something is again not meshing or not working as we would like it to. And as we are kind of thinking about these adaptations, we need to have trust with our collaborators to be able to tell us, hey, that wasn't working, and to air our differences in a civil manner, respecting each other and respecting each other's knowledge. And again, recognizing the different roles or the different viewpoints that we're holding at different times in that process. So I always say that as an individual, I need to be conscious of the multiple identities that I hold. Sometimes my identity as a mom is showing up. Sometimes my identity as a wife or a woman is showing up. Sometimes my identity as a professor is coming into place, or with my ethnic or racial backgrounds. And I need to think about how those different things motivate me, even in ways that I don't know. And then exploring our own strengths and weaknesses. And as we work together in collaborative services, all of these individuals that are here today, I think a strength is that adaptability and that curiosity that Deb mentioned. And when that is there and present, again, thinking about how we are making those congruent actions together to be authentic and to be honest with ourselves and with others, and making sure that our actions are consistent with our beliefs. So this is an activity that I have both students and professionals do that has been very meaningful as I thought about my own lens. But I see a lot of meaning for thinking about how that facilitates those group discussions. This is page 1 of 2, but on the previous page, you ask individuals to circle all values that they hold or that they think are important. And as I will walk around and see papers, or I'll ask people to share a screenshot, oftentimes they've circled just a ton of different things. But the next step is thinking about how to put those together in a group, 5 groups, and then thinking about a heading. So for example, in this example, we have independence being reflective of abundance and growth and wealth and security and freedom. But independence might be openness to somebody else, or it might be an ability to engage in our spirituality, or it might be thinking about how we have been able to be innovative to enable different things that we want to do. And so the more that we know our mindset as healthcare providers and how we're providing that in care, that really helps us. There are a couple other things that we do to really engage in this discussion of self-awareness as we work together. One is a free personality test, and I will ask in a minute each individual one by one to share their personality profile that they put together. Another is the CQ, or the Cultural Index, and I am a trainer for that. It asks you to start thinking about how you develop initial baseline knowledge, and it says we have to develop knowledge about different cultures, and that might be the medical culture, the pharmacy culture, our particular self, or a location. We have to have a desire. So we have to be motivated to, again, take those steps. And then, as Deb mentioned, to really apply that and adjust that as we look at care. And then coalition training really builds on focusing on working across differences, working with conflict and controversy, and getting to that, again, agent of social change model. So there's a worksheet and activity that we do that really looks at those lenses, and are we applying something to kind of correct a problem that is a magic bullet or is paternalistic. So it asks you to think about your change model. And then photo voice is something that we have actually just published an article on, but looks at having individuals look for social determinants of health in their community, and taking an image, not with patients or individuals in there, but discussing what that image says. An example that occurred in my class this year as we were preparing was that one student saw a car sitting in our community, and said that to her, this car that was parked was viewed as a symbol of wealth, and a symbol that you could afford to have a car, you could afford to have transportation. Then the individual who actually had taken the photo spoke up and said that actually the car was a car that somebody was living in their car, that they had been experiencing homelessness at that point, and that person had been relying on that for their place of residence. And so it was, again, just this interesting thing to think about. Okay, how do we address that? How do we provide care in that circumstance? Or how do we recognize that we had looked at that moment in totally different ways? Okay, so I am going to ask Jane first, and I'll explain a little bit what that is. Jane, are you an extrovert or an introvert in your personality, and what is your Myers-Briggs profile?
So thank you. So I'm more of an extrovert, and I'm an observer. Those are my two key strengths. I take in checking things out, things that aren't, I analyze a little bit, but I'm more extrovert, so I share a lot of the information that I have. And as a collaborative group with our team and the community we serve, we're able to balance that and come up with the best solutions.
Yes, and I'm putting, feel free to put in the chat your Myers-Briggs personality if you know that, because again, I think this is just really interesting to think about how we balance each other. Jane balances me. I am an INFJ, and she balances me because I can be too intuitive or I can be too introverted, and that again, can just create problems with how I am approaching the situation. So I'll ask Jane sometimes to be more vocal for me, or to speak up, or she'll speak up when she notices something with how we've designed something. And again, she might take a moment to think about how that is looking in a different way than I do, where I am able to see ideas and connections. Carlton, Ashley, Deb, what are your personalities?
I can go next. So my Myers-Briggs, I'm very, very extroverted, almost to a fault sometimes. But my Myers-Briggs is ENTJ, so I also have that intuition, also the thinking and analysis and that type of thing. And then the judging is more about being organized. I actually just looked up the top careers for an ENTJ, and the top one is a program manager, which I thought is hilarious because that is my actual job title. So I think that I'm fitting in perfectly with what Myers-Briggs has as a good career for someone like me.
Definitely so. And Deb, what about you?
So my 16 personalities test, when I took it, tagged me as an advocate. And it's an interesting title for me because that resonates with me. I can be really extroverted when I'm advocating for a person or a cause, but in reality, I'm very introverted. I need some real alone time to recharge. For me, the key thing about being an advocate, like I sort of love that title, but it's really important to me to make sure that I'm not just advocating for what I think is the best, but for what the people that I'm advocating for, what they think is best. One of my
Yes.
mentors here at the University of Iowa is a gentleman who recently passed away, Sandy Boyd, an amazing, amazing person. He used to be the president of the university, Chicago Museum of Natural History, and he always talks about doing good well. And what that means is that when you're trying to do good out there in this world, but that you're not just thinking about what you think is good, what you think is doing good well, but you really dive deep into trying to better understand how what you do makes a difference to the people you're trying to serve. So being an advocate is something that really resonates for me, but it takes a lot of research and work and sort of self-reflection to think about what that means.
Yes, and I am an INFJ, which ends up being in that grouping of advocate as well. And for me, sometimes it is remembering to advocate for myself. I will so heavily dive into the thinking about others that I will start to think about, oh, this is maybe not sustainable or feasible for me to do that. And how do I communicate that? And how do I connect with both of those identities so that what I'm doing, I can do for the long haul. And then again, that ability to recharge, those are the times where, if we are introverted, Deb, I think then we need to call on a Jane or an Ashley to see us in different ways or, again, to collaborate in that team manner that they are helping to carry us through in those different times. And we're recognizing the strengths that we have. So I think as I have evolved as a healthcare professional from talking to you, from talking to other mentors, that has been something that I recognized was really important. At the start, I would not, and I would get to a point where I felt crabby or tired or again, unhappy, and I needed to modify what I did.
Yep.
So thank you for putting that perspective in. I wish I would know your mentor too, but I think we have some, again, great individuals that we can look up to and continue to connect with to evolve. And again, our friendships and our relationships and the development of these services should be really focused on this cultural humility aspect. Again, we've talked about how we've held each other accountable, but we also need to talk to our students and our team about that. So it's not just gaining some cultural knowledge and saying these are different facts in a particular area or a particular approach, but again, thinking about how that accountability is there. And then again, trying to address different imbalances and power imbalances that we can have to think about that equity and to make sure that we're having those different voices heard in different places. And I am sure hoping that Carlton has been able to join us. I've been checking in on him as we go. Carlton, are you here with us? I'm hoping we've gotten him into the meeting. Okay, well, I am going to ask Jane and Ashley to pinch hit, and I will try to introduce Carlton to all of you. Carlton is an amazing friend and pharmacist. He works for Jolly's Pharmacy, which is based in the Caribbean. His boss, Orin Jolly, actually just lectured in our travel medicine elective yesterday. But Jolly's Pharmacy is one of our partners in Dominica in the West Indies. Carlton is a partner. And he is just a amazing person for really everything that he accomplishes or he does in the development of services. When we are walking around Dominica and we are going to different activities with him, everybody knows him and everybody is saying hi to him because he's really become an integral member of the community. And Jolly's Pharmacy, if you look them up, has won a lot of different awards with the Caribbean Pharmacist Association Carlton as an individual, Oren as an individual as well, again, for their innovative services. Carlton's boss, Oren, trained at the University of Washington in the US, but he decided to return to Dominica and begin to take over his dad's business, and to further develop Jolly's pharmacy over time. His brother Andy lives still in Washington State, and he was talking yesterday about how they apply similar models of ingenuity to the things that they provide. So Carlton is our partner there, and again, a amazing resource. And I hope that if he's here, he will jump in with us. I know we were having some technology issues as we work together. But in Iowa, we're in the center of the US. And again, it takes us about 2 days when we fly down to Dominica to get there with our overnights and our flight status. But Dominica is located in the Caribbean between Martinique and Guadeloupe. It has more of a British and a French background, a little bit of Spanish, again, in the history of the country, but mainly the British and the French. And there are Creole dialects that are spoken in Dominica, although English is the primary language. It is considered the nature isle of the Caribbean, and the structures that exist, the preferences, the food choices are different from that of Iowa, but they're also similar, and I'll have Jane touch on that. And then again, partnerships can be both public and private. So although we do work with the Ministry of Health, Dolly's Pharmacy is an example of a formal private partnership that we've had for about 15 years. I was married in the island of Dominica when I was finishing my graduate degrees and studies, and I got sick, and some individuals in the community helped me with traditional healing, and again, connected me to different health resources. And that was really a pivotal moment for me to think about, again, just the different approaches to healthcare and how we do those things. As Carlton works with our team, and he is there, one of the things that I think is so important that he does is that we will pre-train students in the process of knowing about pharmacy in Dominica, about knowing some of the background and culture, some of the historical components, and the pharmacy systems and laws, and again, the pharmacy educational approach. And that is a part of a global health mindset, again, to think about how we are being appropriate partners if we are doing international work together. But one of the things that really has to happen when we're there is that Carlton is instrumental in helping to kind of think about the application of that and to reinforce different messages, or to think about, is there anything that we have not gotten right as we provided information? So Jane, you see the script at the top. It is, again, just kind of a script that would be written in a patient medical book. How do students sometimes kind of struggle with that, especially as time has went on?
Okay, so early on, they did pretty well when they were examining these prescriptions. However, the earlier days, as we get later days, because we're digitalized in the United States and everything is electronically sent to the pharmacies, they actually struggle being able to read the prescription, being able to see what is going on. For here, and my best thing to be able to look at it is if they are getting, it looks like it's a 500 milligram dosage of a medication, and they're to take it one as needed every 8 hours. Our systems do things a little bit differently than their systems, and these are usually done in a notebook. We have medical records or electronic records that are kept over in Dominica. They have a notebook which is scribed that goes with the patient throughout the healthcare system. So that's a little bit different. They really empower their patients to be able to understand their healthcare So that's a little bit different. I feel in Dominica, which is a positive, that I wish more of our patients in the States would be able to do that as well.
Yeah, so Carlton really talks about that application, talks about those differences. Ashley, as she spoke with Carlton, and talked about the different systems and infrastructure they had with IT, needed to kind of think about that as we were thinking about the design. And again, this certainly applies to Deb with Open Heartland as well too, in thinking about the various ways that we manage our health and how we are reinforcing how those systems work together as things evolve over time. You can also see that Carlton is showing some of the natural products that are compounded and some of the products that are compounded with Jolly's Pharmacy. And again, they will talk with students about the differences in pooled procurement and procurement processes that occur on the island and how that affects the availability of medications or services. The other picture you see is also, again, going to the compounding pharmacy that Jolly's owns and seeing some of the processes that were used to design those products. And again, students had, contributed back in the development of some additional trainings for compounding for technicians or different protocols and resources that were there. But again, as you are doing international work and you're looking at your services, whether local or abroad, you really have to think about, again, how those services continue on without just you. So one of the things that Carlton does to continue to build capacity over time is talks with different schools and different ages about expectations and exposure and experiences, creating and fostering those relationships and those connections to the profession over time. And so when we are collaborating within that structure, our goal is to reinforce some of that and to be an additional resource. So we have talked about pathways for health education. We have some of the pharmacists at Jolly's that are graduates of UTech Jamaica. And we have also collaborated in those capacities as well through writing and scholarship. And we will make those connections. We'll talk about ways to further your pharmacy education and degrees, not only from, again, other Caribbean institutions, but then thinking about pursuing different degrees outside of the US, if that, or outside of the Caribbean, if that is something that the students really want as well. So thinking about those educational systems. And then again, the continuing education components are always collaborative. Jolly's has went to putting those online over the years due to preferences of getting everybody home and again, feasibility and continuity. And so an example of a topic that was brought up by not only the Kalinago chief, which is one of the indigenous communities or the indigenous community in Dominica, was thinking about how we use traditional healing, integrative medicine, and whole person health within our system, and how we can respect those health beliefs and utilize those together with prescriptions and over-the-counter medications. So we will talk about pharmacognosy and ethnopharmacology, and then Carlton builds upon that and makes those connections. Jolly's also has been very innovative in working with health promotions and working with a local radio station. So Carlton is the local host of something called Health Vibes that has call-ins with different topics. And again, building upon that topic this year, that was also the topic for the discussion with the community. And he will bridge again those different understandings of how that works together and how we are understanding each other with those different things. So we'll provide a perspective and we'll ask each other different things as we're working together. So I think in the picture, one of the students is talking, but I had also showed Carlton something to see if, again, that was just checking out with an approach that would be utilized. So Jane, I am going to ask a couple of questions now. And again, Jane is an instructor at Albany College of Pharmacy and Health Sciences, and she is an adjunct faculty member at the University of Iowa College of Pharmacy. As I mentioned, she's traveled for countless years with me. Jane, I want you to walk us through, again, how we kind of teach students to adapt in that process of starting with the material and the pre-training and the preparation and working with them over time, but applying it differently there.
So the way we approach that is they have their training. Actually, as they apply for this rotation to go, we actually try to meet with them. And we do meet with them on a regular basis. Those faculty, the adjunct faculty that come and assist Janine, we meet with them and introduce ourselves. We try to get them to get to know us a little bit before they spend that quality time with us when we are in Dominica. The approach has gotten better because we're more frequently the adjunct faculty that are there. We spent a little bit more time, and the students really enjoy getting to know us prior, or at least me, prior to going to Dominica. So they feel like there's this connection that has already helped, that is readily available to help them. And once we kind of share our stories, how our transitions have happened, on our visits, my visits on Dominica, how I've grown. They ask a lot of intuitive questions, but a lot of it is about the lifestyle and kind of how I perceive certain things. We can tell them a number amount of times of, what they need to do, how to prepare, keep an open mind. Most of it, the physical piece, we try to get them to, make sure that they're, in good walking condition. We do have some runners, but most of them are primarily walking, but the altitude is or the terrain is very different than what the individuals from Iowa have. It's primarily flat. So when we tell them that, it's a, few minute walk up to their room, but it's all uphill, they are out of breath and, don't take, that seriously until that first day. And then they get involved. They get excited about the community, excited about learning about the foods that Dominica has, and what it has to offer. They are primarily a fish-based protein with plants as well, beans. So most of them are able to adapt with that diet. Over the years, the students have not encountered anything that was different from the US. I mean, they seem to have eaten healthier. The freshness, the produce that is grown there is amazing. So we've talked about that. We talk about the differences when we talk about disease states with diabetes, that, we need to know what fruits are in seasons. Their seasons are very different from ours, but they have lush vegetables, as I stated. They've got mangoes, avocado, depending on the time of year that we go. They're fresh grapefruits, coconuts, bananas, but primarily, like I said, their diet is protein. So is fish. We know that when we're talking to them about the diabetes, we try to really get to know how their daily meal plan works. In Dominica, their main meal is primarily in the afternoon, is their lunchtime meal, is their largest meal of the day. And then usually at nighttime, they may have soup and maybe a bread choice or starch choice. And then for breakfast, they will have eggs and maybe a traditional coffee that is known as cocoa tea. So it is cocoa based, and they may add some additional caffeine in it as coffee with it. They will put herbs in it as well, and that's how they start their day. We need to make sure that we take into consideration if they're adding a sweetener to it or how much outside sugar they're adding. So we talk about that, and that way they kind of know when we're going into counseling patients, when we're doing a screening, we have an idea of the Caribbean cooking, and what their primary diet is.
So Jane, I know one of the things that I have talked about with you too is that at first we thought, as we were developing our partnerships, that some of the vegetables that maybe somebody was referring to were, again, leafy greens when we were using the term vegetables. And over time, we found that some of the varieties that they were referring to were really the root vegetables and the plantains. So while we were thinking that we were making some initial recommendations and counseling that were appropriate, and maybe again some of the truth or the components of what we were saying were the right thing, the stews, the dishes, we needed to adapt to think about what does that word choice mean with that. So can you mention how you've changed in that over time?
Yes. What we did was we learned that we needed to make sure that they knew portion controls, because the root vegetables, which are plentiful there, were their starchy vegetables. And when we first realized they were probably, if you look about at the plate, that was probably I'll say at least half, if not more, of what their intake was. So we needed to understand that they needed to modify, reduce that amount, maybe add additional protein, which would be the fish. And then if they could get the leafy greens in there, they would. One other thing we needed to make sure is that when we were counseling them, a lot of the Dominicans, they walk everywhere. For them, it's nothing to walk, 5 miles a day just to get to work, and they do it in a timely fashion. So we needed to incorporate their activity as well. And if they did more activity, then they could have had, all right, maybe a little bit more of those root vegetables, those starchy vegetables.
Yes, that balance of really understanding what life looks like as we're suggesting recommendations and we're working with different populations is important. And even I know we'll build upon this with Deb and talking about Iowa, but again, sometimes we don't have the same infrastructure or transportation system, to connect different locations, different cities. I know when I was in New York living, I really loved Amtrak and the train to get to the city from upstate New York. So Jane is in upstate, and that was great for feasibility of, going from one place to another. But in Iowa, again, that's a little bit harder to get to. So that might impact somebody's activities. Or thinking about, again, both Jane and I have those really cold winters. And we're in the middle of, I say, third winter right now, where we've gotten warm and then we've gotten cold again, and thinking about what activities the patient could do or what will seasonally be appropriate and readily available. And again, how that relates to just dietary preferences and choices. So Grow Johnson County is an example of a local organization that plants things and works with our mobile clinic and Open Heartland to make sure that resources are available. They talk about thinking about food choices that would be universally available throughout the year, and then again, customizing that food choice with those additional pieces of that timing that you mentioned. So Jane, I know you do a great job with the students. Again, students are paired, and we are overly heavy sometimes with preceptors, both local and abroad, just to make sure that we are thinking about making sure how we are doing something is appropriate, and then showing it how the follow-up continues between different visits that we have. So thinking about telehealth, thinking about, again, those WhatsApp platforms, thinking about those things that Ashley designs as well. So thank you, Jane, so much for kind of talking about that adaptation. Deb, as I mentioned, again, started an organization called Open Heartland in the Iowa City community area, and we have her information there. But as we also talked about, Deb works both locally and internationally. in the provision of care. So Deb, can you kind of talk to us about like this concept of sustainability and then thinking about all of the influences that are important?
Okay, very simple question, Janine. So Open Heartland is really unique. We're very young as a nonprofit organization. We're only 5 years old. We incorporated as a nonprofit the year that COVID hit. And I think one of the real advantages Open Heartland has is that we started this organization with no preconceptions about who we are or what we're going to do, other than what resulted from talking with the families that we're serving. So we started in year one working with about 50 Latinx immigrant families coming here from Central America and Mexico. Now, 5 years later, we're working with about 400 families. Excuse me. And so I think one of the things that has made our organization's work so successful and sustainable is that idea that we came from no preconceptions. All programs, all activities that we do not come from the top down. They don't come from the board of directors. They come from the families. We have a leadership team that's made up of primarily women who represent the different local communities within Iowa City where our Latino immigrant families live. And we meet regularly. We're actually meeting tonight. All of our meetings are bilingual, Spanish and English, and these leaders of their communities are the ones who determine what our programs and activities are. This is where the mobile clinic came into play for Open Heartland. I think what makes us sustainable is tying the work we do locally to a global aspect. So you can see on the screen that Janine has pulled up that Open Heartland works to help activate some of the United Nations 17 Sustainable Development Goals. We really try to work toward helping in poverty. We have lots of training programs. We help provide zero hunger by having a food pantry at Open Heartland. And it's interesting that you were talking, Jane, about the types of food that your families, that your patients in Dominique eat on a daily basis. We've encountered some really interesting cultural aspects at Open Heartland because the vegetables and the produce we grow here in Iowa are very new to the families that we serve. So for example, tonight, of course, we're having food at our meeting. We always do. And one of the things that I'm personally making is a broccoli salad. Broccoli is not a vegetable that's common to the culture that we serve. And so we're doing a little taste testing tonight to see if we can tempt our families to start eating more broccoli. We, of course, contribute to good health and well-being. We work with quality education. We provide English classes to families who English is not their first or second language. We try to work with reduced inequalities and peace, justice, and strong institutions. Many of the families that Open Heartland works with have come from places of severe poverty, of violence, of lack of opportunities for their families, and that's why they are here in Iowa, in the United States. Open Heartland works really hard to try to support these families in whatever ways they need. And so I think, Janine, the question about sustainability really comes down to our organization responds to what our families are saying they need support with. It just comes down to we're not making those decisions, the families are making those decisions.
And Deb, I think I love, as I've worked with you again, that we have incorporated that into thinking about the model with mobile clinic. And again, what we would like to do, thinking for the different refugee populations or the different groups, how are they informing us? And again, what is our preference for what we think needs to be done? But again, how are we spending the time to hear the needs and the discussions there? And I love that you're taste testing broccoli because again, you know, I think it has to be something that you like. And then even the preparation of that, what you're adding, as you mentioned, influences how we have an experience with those different things. So I know Grow Johnson County and some of the things that we'll do with an upcoming speaker symposium at the University of Iowa is related to that, thinking about what does it look like differently when we have different food sources? What are those preferences that are available when we're in a different location? And what are families likely to use? And then what is the cost associated with that to, if we're making a lifestyle intervention and telling somebody to do healthy eating, is that feasible in a way that somebody thinks, or what does that mean?
One more example is the aspect of education. Janine asked me a couple months ago to try to schedule some vaccine education for the families. I took this to the leadership team, a group of like 20 women, and basically they said, we don't have time to come to a workshop about learning why vaccines are good for our children. Just please come and bring the vaccines. So Janine and I are going to have to be really creative in how we weave the education into the clinic where we actually give the vaccines.
And this is a great example. Deb and I had pre-prepped for this yesterday, but as we were talking, I was messaging with our student president. We have a student president that's part of the board, and explaining some of the things that Deb does, again, with this global and local component, and mentioning some of those things with thinking about we have to go back to the drawing board in different ways as time evolves as well. So, again, what Deb and I faced for that in COVID was very different. It is relearning that lesson as she has provided those different pieces and that feedback. So Deb, I know that you had said with global health as local health that we both faced this, again, thinking about not only the development of services in the Iowa City area and with, again, refugee populations or different diverse populations we work with, but then in Guatemala, as you are there, how do you create that that mindset that, what we're doing is interconnected around the world?
I think in response to that, the answer would be that everything we do locally has a global impact. In order to change the health of the world, you have to start locally. And thinking about how we're all connected, that local work that we do, how we're all connected and helping to change a global aspect, I think is really important. When we are doing our missions in Guatemala, one of the things we did this year is we brought a surgical nurse from a town in Iowa whose son was also born with cleft lip and cleft palate. And the nurse brought all the photos of her son before surgery, after surgery, playing with his grandma, helping take care of his sister, just to help form that connection that you in Guatemala are not the only family that this happens to, that this happens to families all over the world, that there isn't something less about you or something wrong with you, that this has happened to you, that your child was born with this birth defect, but that this happens to everyone. It's a common thing, and we have things in common. We're just like each other. And sort of bringing that local to global on that level, I think makes a big difference.
And going back, I put in the chat after I talked with Deb and heard what those women said, I thought, yes, I am a mom. I have a 9-year-old and an 11-year-old. And would I want to go to a session at 8 or 9 o'clock at night, learning about something? If I was thinking about getting them to just all of their different activities and all of the different hats that I wear. And I thought, no. We've talked about Instagram, like short posts with information, or we've talked about, I talked with the president about tying that to an event that Deb is having. So she had suggested oftentimes the places that we see the greatest effect is a back to school event where there's, bicycles and services offered. We participated in your, you have a big holiday celebration in December for different holidays. And you gave out, how many presents did you get from the local community or resources or different things this year?
I think this year we had about 375 families involved. That was over 4,000 people, so probably about 7 or 8,000 gifts to people. And Janine, that's a really good point. One of the ways that we bring health education into the work we do at Open Heartland is we bring it into an event that's active and fun. There's food, there's games, there's activities, usually there are prizes, and integrating the health community into that makes the health community part of our community. Doesn't make you separate.
I've loved that. And I know Carlton does that too in Dominica with health and fun runs, or providing some support at Carnival or different celebrations again. So it might be saying, oh, we've thought about providing this at a monthly clinic, but maybe that's not how people want that to happen. And so again, shifting that mentality to like, maybe it happens at the December event, or is that good at the December event if it's cold and some of these things are outside? Do people really want to stop and get a vaccine? Or
Right.
is it better back to school when we can capture people kind of outside? Capture is a bad word of a choice for it, but like have people there outside and, have some different space and different time to do that. That also works within that system of what the local schools are requiring for those individuals too.
And Janine, one of the little sort of tricks that Open Heartland uses is we have on our back to school event where we do invite the pharmacy group to come in and do back to school vaccines. We have a children's activity passport. And so if you do all 12 of the passports, you get a special prize as a child. And so of course it's your choice whether you want to have the vaccine, but it's sort of part of the lineup of events. So it's just kind of a natural thing to do.
Yeah, Deb, I know you and I have talked about again that we have to keep reflecting on this, and oftentimes we look to each other to reflect. I've said sometimes to Deb, if I'm working with somebody that doesn't do both work locally and globally, sometimes I will talk about how things intersect, and they might say, I don't see that connection. Deb, you have always, again, validated, again, thinking about those different applications and you experiencing different things as well too. And that has came down to, as we even talked about spending time in the community and spending time throughout the year. So I know you gave that example, but you mentioned spending time was important outside of just doing your service when you went to Guatemala too, correct?
Right. For me, I took on the leadership role in our medical mission to Guatemala. I organized 2 medical missions a year, one for cleft palate, one for cataracts. And I always spend at least 2 to 2.5 weeks studying Spanish in an immersive program where I'm doing a homestay, living with a family. I study Spanish all year long with a woman, an indigenous woman from Guatemala. Most of our lessons are not spent on vocabulary, they're spent on understanding better the culture of Guatemala. And that has made a tremendous difference in how we facilitate the mission that we do when we arrive in Guatemala.
I think, again, connecting with you, connecting with your mission in Guatemala, spending time with Open Heartland, thinking about, again, we work with community health partners and child life specialists doing teddy bear clinics with vaccines for kids. Again, learning more what life looks like in different places, what life looks like in Dominica. Not only, connects us as human beings, as people, but it makes that work, I know, so much more meaningful to me when I'm thinking about the people that I'm working with, and just, again, what life looks like for us and for others too. So thank you, Deb, so much for that. Ashley also has a role with Deb and Open Heartland, again, in thinking about this idea of overlap. And so as we look to develop systems for Dominica, one of the systems that we tried to do was a electronic health record that ended up having zero support. And I said, data went in, data did not come out without a lot of effort. And so Ashley, I called upon her to say, Ashley, this system isn't working for Open Heartland. It's not working for Mobile Clinic. We had tried to use it for Dominica again to think about the continuity and the resources with the Ministry of Health and to talk with Jollies and Jungle Bay. But how do you look at, again, that effectiveness as a tool and thinking about can it be applied, longitudinally, especially as people move different locations and have different roles?
Right. So when we think about an effectiveness of a tool, we're trying to understand, look at these questions here, right? Like, does it actually accomplish the task that we need it to accomplish, right? There's a bajillion questions that we really have to ask before we're able to use a new technology, and it comes with a ton of background research and analysis. One of the things that we have to consider, especially in our case, is because we're looking at Open Heartland, we're looking at Mobile Clinic, we're also looking at Dominica. Those are three vastly different patient populations. Their needs are different, their health beliefs and behaviors are different. So what sort of technology can we use that is able to meet all of those different patient populations, right? And not just the patient populations, we also have to think about the users. Something that's very complicated for us to consider in a grand scale of things is that, especially in a health record, is you have many, many, many end users, and they all have different roles, they have different needs. We think about how the people are actually interacting with that software, and then we need to think about patients as well. If they want to see their own health information, how do we get that information to them? Are we able to communicate with them directly through that health record? Because this is a collaborative relationship, right? We don't just tell patients what to do, we work with them to help improve their health. And so we have to have a good communication option available. And so thinking about the different technologies that exist, finding something that's got sort of a base layer of some basic functions and trying to expand upon what your different needs are. And like we've discussed already, being adaptive, being creative in those solutions, looking for ways that you can, again, customize and modify as needed in order to meet those needs. And a lot of that starts with, you have to start with that group of stakeholders at the very beginning before you start working your way down this process, right? Because like you've mentioned before, we may know what we think we need, but when we talk to an end user, me from the development side may not understand exactly what that end user is thinking and how they need it to function. And so we need to have that conversation longitudinally and have everybody at the table at the beginning in order for that to be successful.
And I really love, again, that Ashley kind of speaks both sides of that coin. Again, she thinks about that experience as a user or a patient. She thinks about her informatics hat. She thinks about her pharmacy hat and collaboration. I did want to share, again, thinking about those unplanned challenges that we have. Carlton has messaged and said that there was illness in the pharmacy and that he pinch hitted at the last minute and he stepped in to cover that, which I am greatly appreciative, again, of thinking about that. But part of that adaptability too is thinking about within that, how do we step in and we cover each other in different ways? And I know, Ashley, we've talked about with this, just thinking about how we might use something might not be the same as somebody else. So we have started the process of kind of doing some of those things, but we mentioned an example of a technology that didn't work. Ashley, I also shared with you that we did a survey of the teams that we work with for Open Heartland, for Mobile Clinic, to look at their preferences with different key components. And I found that students and practitioners did not want to complete a survey on different tools and key components. They didn't want to use it. They learn by experience. And so I had to go back to the drawing board of I think, again, we were kind of having semi-structured interviews and focus groups, and you were doing a lot of that in Dominica this time in the midst of our precepting as well to kind of get that input from individuals. And what are some of the things that they gave you as insights? And I know we're towards the end of our time, but I would love to hear that.
Yeah, so I think our biggest barrier that we have to consider, especially in Dominica, is just accessibility, right? So can we have this software available on a laptop that we can take with us places? Is there capability to have a server available where we can actually store this data? There's different needs, right? So like Jolly's, an existing organization in pharmacy, they have a lot of that infrastructure that already exists. So we may not have to focus on that quite as much with that group. But if we think about when we're doing health screenings out in the community with the students, they have their laptops and that's all they have. Making sure that we have a good internet connection, making sure that the health record or what software we're using is able to run on the internet bandwidth that exists, right? So is it streamlined? Is it simple to use? Can they get through an interview with a patient in 30 minutes going through this information and being able to provide recommendations, right? So we're talking about space, we're talking about internet, we're talking about time, usability, being able to communicate that with the patient. So there were a lot of different things we had to think about, and noticing that there were a lot more needs when we think about going out into the community. So maybe we need to focus on trying to meet those needs first, and see, how we can make this work in that setting, and then bringing that back and, start working out a plan to implement that.
As I talked with both individuals here, and then as we conclude today, I thought back to a global health conference that Ashley and I presented at New Haven, Connecticut, and I found a lot of my notes connecting to mobile health, and I was referring a student back to that and saying, many of the patients that we work with at Open Heartland and also in Dominica will utilize their phone. So just thinking about how phone technology connects to laptop technology. And I wanted to share that, I've mentioned to Ashley multiple times the work that she started as a student. We actually thought we were programming a clinical decision support app, and that has evolved over time within the capacity of a grant to be clinical decision support, but in terms of utilization in existing apps and within open source technology and EMRs. So again, the patience in that, and again, the continued collaboration with Ashley and everyone is appreciated. So as we end today, I just want to say that Ashley, Deb, Jane, Carlton are all great examples of just working together to address all of those issues. And I hope that this has given you an example of ways that you can apply the work in your own country. But again, we can think about how we make those interventions in a larger model in pharmacy, both internationally and locally, and how we are developing trainings and education to enhance the tools and resources that we have available to our patients in care. I just would like to let you know that we have a town hall coming up for the academic section advocacy, policy, and change management working group. And we would love to see you all there to get your insights onto how we can do this in ways around the world throughout the different WHO regions and throughout your countries to make a more sustainable impact, and to think about what is unique to each of us and to our professions in the different countries that we represent, but also what is the same as we look at those pieces as well. So I hope that this helps you to provide the care to your patients, that you think about those teammates around you that may or may not be in pharmacy, that may or may not have the same skill sets as you, that may or may not have the same personalities as you. We certainly hope that you'll connect and you'll continue to stay involved with FIP. And we know that you are providing amazing services worldwide. So thank you for that. And again, there are different references and resources at the end that we hope help you in your journeys for this. I know we're a little bit over in time, but I wanted to say thank you for sticking with us today, and thank you for everything that you do and for being a part of our organization. I continue to learn so much from every partner that we work with FIP, and I'm grateful to have the opportunity to be in those roles. And Deb, Jane, Ashley, one of the things that we've been asked to do is to take a screenshot. So if you'd love to turn on your camera, we'd love to take a picture with you. And thank you for being here with us today and being a part of that. This has been incredible to get the opportunity to just demonstrate the things that we do. And Arianola is here as well, and she is a part of our executive team, and she is putting up with me and in going over. So we want to thank Arianola as well.
Thank you.
Okay, a blessed day, everybody, wherever you are, whatever time it is. And we will look forward to working with you in the future.